In the name of Allah, the most compassionate, the most merciful. Salam everyone, I hope you are doing excellent. In this session, we are going to talk about GFR or glomerular filtration rate. GFR is the amount of plasma that is filtered through the glomerular capillary into the Bowman's space every minute. GFR is determined by two main factors: filtration coefficient and net filtration pressure. By multiplying these two factors, we can calculate GFR. Filtration coefficient itself is determined by the properties of filtration barrier such as permeability, surface area, and temperature. And by increasing these factors, filtration coefficient will increase because they are directly proportional with each other. And also the thickness of the barrier, that filtration coefficient is inversely proportional with it. As the thickness of barrier is increased, the filtration coefficient will decrease. The filtration coefficient of glomerular filtration barrier or glomerular capillaries is much higher compared to any other capillary beds filtration coefficient in any other part of the body. Any factor that increase permeability of barrier or its surface area or reduce its thickness will increase filtration coefficient and will increase the amount of plasma that is filtered from the glomerular capillary into the Bowman's capsule. Net filtration pressure is the outcome of stalling forces through the glomerular capillary. Two of stalling forces inside glomerular capillary, including hydrostatic pressure and colloid osmotic pressure, and two of these factors in the Bowman's space. The hydrostatic pressure inside glomerular capillary favors filtration, but the oncotic pressure that is determined by plasma protein opposes filtration. On the other hand, in the Bowman's space, hydrostatic pressure opposes filtration and osmotic colloid or oncotic pressure inside Bowman's space favors filtration. But the values determine the final or net result. Let's consider the values. The hydrostatic pressure inside glomerular capillary is 60 mm of mercury, favoring filtration, but the colloid osmotic pressure is 32 mm of mercury that opposes filtration. In the Bowman's space, because of insignificant amount of proteins, the osmotic colloid pressure is somehow near zero and it is negligible, but the hydrostatic pressure inside Bowman's space is about 18 mm of mercury. So here we have two opposing factors, two opposing forces, and one favoring forces. By considering the values, 60 for hydrostatic pressure of glomerular capillary, 80 for hydrostatic pressure of Bowman's space that has a negative effect on filtration, and also the oncotic pressure of glomerular capillary 32 that also has negative effect. By summation of this value, the final result will be plus 10 mm of mercury that favors filtration. But the values at the afferent end and efferent end differs in some way. For example, hydrostatic pressure at the afferent end is a little higher compared to efferent end. And also for oncotic pressure inside glomerular capillary due to the plasma proteins, at the afferent end, it is somehow smaller compared to efferent end, because by filtration of 20% of plasma into the Bowman's space, about 20%, the plasma proteins are concentrated to the end of a glomerular capillary, and at the efferent end they are higher compared to afferent end. At the afferent end it's about minus 28 millimeter of mercury, but at the efferent end it's about minus 35. So the afferent end favors more filtration and efferent end favors less for filtration. Regarding oncotic pressure inside glomerular capillary, it's just for reminding you that during filtration of plasma from glomerular capillary into the Bowman space, the proteins are not filtered. They remain inside the glomerular capillary and are concentrated to the efferent end, and because of that the level of oncotic pressure to the efferent end is higher and gets higher. But what determines the hydrostatic pressure in glomerular capillaries? It is mainly determined by the mean arterial pressure and also the resistance of afferent and efferent arterioles. As the resistance of afferent arteriole is increased, the blood flow overall will decrease to the glomerular capillary, and the hydrostatic pressure will decrease, and following it the GFR will decrease. Conversely, if the efferent arterial resistance is increased, again blood flow will decrease to the kidneys overall. But before the resistance area at the level of glomerular capillary, the hydrostatic pressure will increase and will increase the GFR at that capillaries. In some way, it is stated that this increased hydrostatic pressure prevent reduction of GFR. In these two curves, you see the relation between arteriolar resistance and glomerular filtration rate and renal blood flow. Let's consider at first the upper curve. The relation between afferent arteriolar resistance and GFR and RBF. By increasing arteriolar resistance, afferent arteriolar resistance, the renal blood flow will decrease, it's predictable, and also GFR will decrease by decreasing hydrostatic pressure at the glomerular capillary level. And by decreasing afferent arteriolar resistance, overall renal blood flow will increase, and GFR also will increase due to a higher hydrostatic pressure at the glomerular capillary level. The values expressed in x-axis and y-axis is in this way. One is for times normal level, one is the normal level, 2 shows the doubled resistance, and 3 shows the threefold resistance. As you see, as the resistance of afferent arteriole reaches to the threefold of normal level, GFR reaches to the 0 level. And also, as the resistance of afferent arteriole is decreased, both renal blood flow and GFR is increased. Let's consider the lower figure. It is more important. considering the relationship between the resistance of efferent arteriole and GFR, and also RBF or renal blood flow. At the normal level of resistance for afferent and efferent, the value for GFR is about 125 milliliter per minute, and renal blood flow is about 1250 milliliter per minute. Okay? When we increase the resistance of efferent arteriole and reach to the twofold level, you see that even though the renal blood flow is decreased due to increased resistance of arteriole, but the GFR is increased than normal level until reaching to a plateau level. But after that, as we increase more the resistance of efferent arteriole, the GFR will decrease then due to reduction of blood flow to the kidneys. On the other hand, if we decrease the resistance of efferent arteriole, you see that overall renal blood flow is increased, but the GFR will decrease because by dilation of efferent arteriole, hydrostatic pressure at the level of glomerular capillary will decrease, and by reduction of hydrostatic pressure here, GFR will decrease, even though that renal blood flow to the kidney will increase. Different conditions can affect the resistance of afferent and efferent arteriole in different ways. In this table, you see the different conditions that can affect renal blood flow, hydrostatic pressure in glomerular capillary, GFR, filtration fraction, and in proximal fluid delivery. Let's at first define filtration fraction again. We have talked about it. Filtration fraction is the percentage of plasma at the level of glomerular capillary that is filtered through it into the Bowman's capsule. So by dividing GFR by RPF or renal plasma flow, we can calculate filtration fraction. Normally GFR is 125, and renal plasma flow, considering it as 50% of renal blood flow, it is about 625. By dividing these two values, filtration fraction is calculated as 20%. 20% of plasma is filtered from glomerular capillary into the Bowman space for both kidneys. Okay. The first condition that constrict the afferent arteriole, the effect of norepinephrine due to sympathetic activation directly by sympathetic nerves or indirectly by the release of hormones from the medullary part of the adrenal gland, that is released into the circulation and reach to the level of kidneys. So this constriction of afferent arteriole and increasing the resistance of afferent arteriole, it's predictable that renal blood flow will decrease due to reduction of renal blood flow. Hydrostatic pressure at the level of glomerular capillary will decrease, and GFR also will decrease. But because both GFR and RPF are decreased, both of them at the same level, the filtration fraction is not changed in a significant way. So you see that filtration fraction remained the same, but the end proximal fluid delivery is decreased. It shows that overall the amount of filtered plasma that reaches the end of proximal renal tubule will decrease because GFR is decreased and overall plasma that is filtered is decreased. The next condition is when the efferent arteriole is constricted or its resistance is increased due to effect of angiotensin II. Angiotensin II has the constricting effect on efferent arteriole. By its constriction, the hydrostatic pressure before this constriction will increase, even though that the renal blood flow is decreased. So the GFR will increase and filtration fraction will increase. You see, the renal plasma flow is decreased, but the GFR is increased more than normal level. Overall filtration fraction is much higher. About 28% of the plasma that reaches to this level will be filtered. But the end proximal fluid delivery is not changed in this condition. What does it mean? It means that the GFR is increased compared to normal level, but because of the increased reabsorption in the level of proximal tubule, the amount of fluid that reaches to the end of the proximal tubule will not change and will remain as the normal level. Let's consider the dilation of afferent and efferent. Prostaglandins are the compounds that has the relaxing effect on smooth muscles. So when they are released locally, they will dilate the afferent arteriole. And by dilation of afferent arteriole, it is predictable renal blood flow will increase, hydrostatic pressure at the level of glomerular capillary will increase, and following that GFR will increase. Again, because both of them are increased, both GFR and RPF, the filtration fraction will remain the same. But again, because high level of plasma is filtered, the amount of fluid that reaches to the end of the proximal tubule will increase. And the last condition, the factor that dilate the efferent arteriole, dilation of efferent arteriole, for example, due to ACE inhibitors. ACE inhibitors, known as angiotensin converting enzyme inhibitors, reduce the level of angiotensin II, and because angiotensin II has the constricting effect on efferent arteriole, by reducing the level of angiotensin II, the efferent arteriole will be dilated. But what is the effect on renal blood flow and GFR? Renal blood flow will increase. It's predictable. Hydrostatic pressure will decrease because the pressure that is applied on the walls of glomerular capillary will decrease because the diameter of the anterior part of the vessels are higher, and this decreased hydrostatic pressure at the glomerular capillary level. So the GFR should be decreased, and the GFR is decreased, but RPF is increased. It will decrease the filtration fraction more than normal level. But again, the amount of fluid that is delivered to the end of the proximal tubule will remain the same because the GFR is decreased, but the reabsorption at the level of proximal tubule also is decreased, and the amount of fluid that reaches to the end of the proximal tubule will remain the same. Drugs known as NSAIDs, non-steroidal anti-inflammatory drugs, are prescribed to reduce pain and also inflammation. But NSAIDs, for example, ibuprofen, naproxen, and some other drugs similar to this compound, has the constricting effect on afferent arteriole. What is the mechanism behind that? NSAID inhibits an enzyme known as cyclooxygenase 2 or COX2. It's an enzyme that generates prostaglandins. So by prescribing NSAIDs, the level of prostaglandins that generated locally will decrease, and reduction of prostaglandin will lead to constriction of afferent arteriole, and by constricting afferent arteriole, both RBF and GFR will decrease. These drugs are contraindicated in patients with renal disease. A correction for pronouncing NSAID drugs: ibuprofen and naproxen. In these figures, you see the relation between renal plasma flow and GFR in upper figure and filtration fraction in lower figure. The normal range of renal plasma flow is about 600 milliliter per minute, and when the renal plasma flow is increased due to increased renal blood flow to both kidneys, GFR is not changed so significantly, because by increasing renal plasma flow, filtration fraction will decrease at the level of glomerular capillaries. But when renal plasma flow is decreased, at first filtration fraction will increase to prevent reduction of GFR to a much higher level, but after that filtration fraction reaches to a plateau, and you see that by decreasing renal plasma flow, GFR will drop so sharply. We previously mentioned that colloid osmotic pressure of glomerular capillary or oncotic pressure will increase from afferent end to efferent end for normal filtration fraction. But when filtration fraction increases, this increase in oncotic pressure to the efferent end will be much severe, much more severe, and if the filtration fraction is decreased for any reason, the amount of change of colloid osmotic pressure from afferent end to efferent end will be much more smooth. We previously mentioned that colloid osmotic pressure of glomerular capillary from afferent end to efferent end will increase, but it is more exaggerated when filtration fraction is increased for any reason, and will be much smoother if the filtration fraction is decreased for any reason. This table provides a good review of factors that affect GFR. For example, here the factors that decrease GFR are presented. The first factor is the reduction of filtration coefficient due to renal disease, diabetes mellitus, hypertension, and aging. These factors affect the properties of filtration barrier, and by reducing permeability or increasing the thickness can decrease GFR. For example, diabetes mellitus by glycation of the capillary bed, capillary vessels, and hypertension by pressure damage to the capillaries, renal disease by any problem at the level of by producing any problem at the level of barrier, and aging that distort the integrity of the barrier. All of them will reduce permeability, will increase thickness, and even maybe by reducing surface area will reduce GFR. The factors that increase hydrostatic pressure inside Bowman's space will reduce GFR. For example, urinary tract obstruction due to, for example, kidney stone. By obstruction of this pathway, the hydrostatic pressure inside Bowman's capsule will increase and oppose filtration, and by opposing filtration will reduce GFR. The next factor that reduces GFR is the increment of oncotic pressure inside glomerular capillaries. For example, when renal blood flow is decreased, by reducing the amount of plasma that reach to the level of glomerular capillaries, and by increasing filtration fraction, you remember from the previous figures that we mentioned that when renal plasma flow is decreased, filtration fraction will increase. And when filtration fraction is increased, the proteins are concentrated inside glomerular capillary, and at the efferent end will increase or will oppose the filtration more. And any factor that increase plasma protein concentration will decrease GFR. Here, the hydrostatic pressure inside glomerular capillary is considered. Which factors can reduce hydrostatic pressure inside glomerular capillary will decrease GFR. For example, hypotension or reduction of arterial pressure or mean arterial pressure. This factor, though, can reduce the hydrostatic pressure in some way, but mainly autoregulatory mechanism prevent the effect of the reducing effect of hypotension on reduction of hydrostatic pressure at the level of glomerular capillary. It is within a range, and out of this range, this autoregulatory mechanism cannot be so effective, and reduction of arterial pressure will lead to reduction of hydrostatic pressure inside glomerular capillaries. The next factor is reduction of angiotensin II, for example, ACE inhibitors or the ARB, angiotensin receptor blockers. This factor can reduce the effect of angiotensin II, and by reducing the resistance of efferent arteriole or dilation of efferent arteriole will decrease hydrostatic pressure. We have talked about this effect previously. Or any factor that increase the resistance of afferent arteriole can reduce hydrostatic pressure. Also, we have talked about it. For example, sympathetic activity and vasoconstriction of afferent by some hormones such as endothelin, norepinephrine, and any other vasoconstrictors can reduce hydrostatic pressure and finally reduce GFR. This table reviews the hormones and autocoids that influence the GFR. Autocoids are vasoactive substances that are released in the kidneys and act locally. The effect of norepinephrine, epinephrine, endothelin, angiotensin II, endothelial-derived nitric oxide, and prostaglandins. Let's see how they affect GFR. As you see, the vasoconstrictors such as norepinephrine, epinephrine, and endothelin reduce GFR, and vasodilators such as nitric oxide and prostaglandin increase GFR. And angiotensin II prevent reduction of GFR. Let's consider them one by one. For the sympathetic stimulation that release epinephrine and norepinephrine from the medullary part of the adrenal gland, and also directly by innervation over the renal vasculature, a strong sympathetic effect can constrict afferent and efferent arterioles and reduce renal blood flow and GFR. This strong activation of sympathetic system occurs during defense reaction, brain ischemia, and severe hemorrhage. But mild to moderate activation of sympathetic nervous system due to, for example, baroreflex and cardiopulmonary reflex will influence GFR and RPF to negligible level, or has little effect on RBF and GFR when it is activated mild to moderate level. So it is important to keep in your mind that strong sympathetic stimulation constrict both afferent and efferent arterioles and increase the resistance of afferent and efferent arterioles. This similar effect is due to endothelin release, due to vascular injury, for example, toxemia of pregnancy, acute renal failure, and chronic uremia lead to release of endothelin, and endothelin will constrict afferent and efferent arteriole and will reduce both renal blood flow and GFR. So vasoconstrictor overall reduce renal blood flow and GFR. Another vasoconstrictor is angiotensin II. We have talked about the role of angiotensin II previously. Angiotensin II mainly is released when we experience hypotension or hypovolemia. For example, when mean arterial pressure or extracellular fluid volume is decreased, by reduction of hydrostatic pressure at the level of glomerular capillary, GFR will decrease, and finally will lead to activation of renin-angiotensin aldosterone system, and the level of angiotensin II will increase. Angiotensin II will target the efferent arterioles and will increase the resistance of efferent arteriole by constricting them, and in this way, even though overall renal blood flow will decrease, but the hydrostatic pressure at the level of glomerular capillary will increase, and angiotensin II will prevent reduction of GFR and will maintain GFR. This maintenance is important for elimination of waste material from body when we experience dehydration and hypovolemia and generation of low volume of urine. We are able to eliminate waste material from our body. because by constriction of efferent arteriole, the hydrostatic pressure at the level of peritubular capillary will decrease, and because of increased filtration fraction at the level of glomerular capillary, the oncotic or osmotic colloid pressure in a peritubular capillary will increase because plasma protein are concentrated in the peritubular capillaries. By these two factors, two stalling forces, both of them favors reabsorption of fluid into the peritubular capillary, and in this way prevent higher volume of urine formation. And by having angiotensin II, we can maintain body fluid inside the body while we can eliminate waste material from our body. It is so important role for angiotensin II. But a question may appear here that why angiotensin II, that is a vasoconstrictor, cannot constrict the afferent arteriole? And afferent arteriole also have the receptor for angiotensin II. And all blood vessels of the kidneys have angiotensin II receptors. But it is due to the presence of nitric oxide and prostaglandins. Both of them play a role at the level of afferent arteriole and dilate afferent arteriole and negate its effect, negate the effect of angiotensin II on afferent arteriole. And because of that, angiotensin II just constrict the efferent arteriole. The next compound is nitric oxide or endothelial-derived nitric oxide that is derived from the endothelial cells of the vessels. The basal level of nitric oxide is important for maintaining renal vasodilation, and it is important for normal excretion of sodium and water. Any factor that reduces the nitric oxide level in the body can increase blood pressure. For example, nitric oxide inhibitors will increase overall vascular resistance and or will increase renal vascular resistance that reduce GFR and sodium excretion. And also anything that damage vascular endothelium, for example, due to atherosclerosis, by reducing nitric oxide, all of them will increase blood pressure. By constriction of blood vessels, by reducing sodium excretion and maintaining more sodium and water inside blood vessels, and in this way will lead to hypertension. Another vasodilators includes prostaglandins such as prostaglandin E2 and prostaglandin I2, and also bradykinin. These are dilating afferent arteriole and increase renal blood flow and GFR in this way. By dilation of afferent arteriole, these factors mainly dampen the sympathetic and angiotensin II effect on afferent under stressful condition. NSAID drugs by blocking COX2 enzyme and reduction of prostaglandin generation will reduce GFR. Let's review the renin-angiotensin-aldosterone system that control blood volume and pressure. Any factor that reduces blood volume or pressure can activate this system. For example, hypovolemia or dehydration due to hemorrhage, vomiting, diarrhea, sweating, burns, high urine output or polyuria, and poor oral intake of water. And also hypoalbuminemia, hypoalbuminemia or reduced albumin level in the plasma, for example, due to cirrhosis or liver disease, or elimination of albumin from kidneys in renal disease. We lose part of the fluid from the body because by reduction of colloid osmotic pressure at the level of glomerular capillary, GFR will increase and more urine will be generated and urine output will increase. In this way, we will experience volume depletion or hypovolemia. Hypotension due to cardiogenic shock due to reduced cardiac output or extensive vasodilation due to bacterial toxin in blood or anaphylactic shock, anesthesia or antihypertensive overdose, we may experience hypotension. Anyway, both of them will lead to any factor that lead to reduction of blood pressure will lead to activation of sympathetic nervous system, and also directly and indirectly by the way of sympathetic innervation will lead to release of renin from the kidney cells. Renin is an enzyme that converts angiotensinogen that is released from the liver. Normally in the circulation, the plasma, we have angiotensin. Tenogen converts this compound, this protein, into angiotensin 1. Angiotensin 1 is converted to angiotensin 2 in the lungs by the effect of an enzyme known as angiotensin converting enzyme. Angiotensin 2 has many different effects throughout the body. It is a strong vasoconstrictor. It increases the reabsorption of salt and water from the kidney. It is an important stimulator of aldosterone release from the adrenal gland, the cortical part of adrenal gland. That also aldosterone increase salt and water retention, reabsorption. And also ADH that is released in pituitary gland when we experience hypovolemia or hypotension. Water retention and vasoconstriction will accompany the effect of angiotensin 2, and also experiencing thirst by the presence of angiotensin 2 and its effect on hypothalamus. We will experience thirst, and all these factors help us to increase blood volume, and also by constriction of blood vessel will help us to maintain blood pressure. By knowing this pathway, several drugs are used to prevent the effect of angiotensin 2 and aldosterone in the body. They are prescribed to prevent hypertension. For example, allospirin is an inhibitor of renin and prevent generation of angiotensin 2 and aldosterone. Or ACE inhibitors such as ramipril, captopril, by inhibiting this enzyme that converts angiotensin 1 to angiotensin 2 will prevent generation of angiotensin 2. ARBs or angiotensin receptor blockers such as losartan will block the effect of angiotensin 2, and also aldosterone receptor blockers such as spironolactone will prevent the effect of aldosterone. All are prescribed to prevent the consequences or the unfavorable consequences of a higher blood pressure or diabetic nephropathy. Here, two important clinical points regarding prescription of some drugs in patients with renal disease. For example, ACE inhibitors and ARBs can be beneficial in some way in patients with renal disease because they dilate the efferent arteriole and lower the intraglomerular hydrostatic pressure and prevent pressure damage to glomerular capillary. But they have some risk for patients with renal disease because they reduce GFR, and it's a risk for patients with renal disease because their GFR is reduced, and by reduction more they will undergo some unfavorable states, and the waste material may accumulate in their body, and the renal insufficiency can be harmful for them. Especially, for example, in patients with narrowing of the renal arteries, that overall renal blood flow and GFR is decreased for them, prescription of ACE inhibitors and ARBs are contraindicated. Also, we have talked about NSAIDs such as ibuprofen that can cause acute kidney injury because they prevent production of prostaglandins and lead to vasoconstriction of afferent arteriole and decrease GFR. So, in patients with renal insufficiency, again, these drugs are contraindicated, especially in patients that experience dehydration or hypotension. Constant GFR is essential for maintaining homeostasis because the kidney's functions are dependent on normal GFR level to process the extracellular fluid moment by moment, and by its function maintain the composition and volume of extracellular fluid. Because of that, autoregulation of GFR and renal blood flow is so important, and we are going to talk about the details of these autoregulatory mechanisms. The efficacy of renal function is clinically determined by the GFR. Let's consider 4 key principles of GFR. The first principle states that GFR is normally very large. We calculated the daily GFR level. It is about 180 liters per 24 hours, or 125 milliliters per minute in both kidneys. This high level of plasma filtration into the renal tubules make sure that even solute with low concentrations in plasma will be detected by the renal tubules, and this helps the kidneys to remove the waste products from the body. And also this high level will maintain homeostasis by processing the plasma at least 60 times per day. And moment by moment processing of plasma help to precisely and rapidly maintain the homeostasis. The second key principle is that blood cells and plasma proteins are not filtered through the filtration barrier. They are maintained inside the blood vessel because hematuria or proteinuria, both of them will waste the cellular and protein part of the plasma, and it is absolutely unfavorable. The third principle is that stalling forces are responsible for the net filtration and also the properties of filtration barrier. And the last or fourth key principle is that GFR is maintained stable due to autoregulatory mechanism, mainly by active change in the resistance of afferent and efferent arterioles. Let's go through autoregulatory mechanism in detail. Why autoregulation is important? Imagine that the blood pressure is fluctuating both in lower side and upper side or higher side. If GFR was dependent on blood pressure, we will experience the fluctuation of GFR in daily life. But even though by fluctuation of arterial pressure from 75 to 175 millimeter of mercury, GFR is somehow changed less than 10% in this higher range of blood pressure fluctuation. And it is important for maintaining normal urine output and also maintaining volume of extracellular fluid. Because in lower blood pressures, fluid will be accumulated inside the body because of lower urine output, and we will experience hypervolemia and hypertension. Or with higher blood pressures, we will experience high urine output and finally we will experience hypotension and hypovolemia if autoregulatory mechanism were not present. Autoregulatory mechanism is an intrinsic feedback mechanism, and even in a removed kidneys outside of the body, we can find this mechanism inside the kidneys. Let's consider the importance of autoregulatory mechanism. For example, when blood pressure increases from 100 to 125, about 25% increase in blood pressure, what happens with autoregulation? GFR level will maintain at the normal level, 180 liter per day. Tubular reabsorption is about 178.5 liter per day. More than 99% of this filtered fluid will be reabsorbed, and just 1.5 liter per day will be eliminated as urine from the body. But if we didn't have autoregulatory mechanism, by increasing blood pressure, the GFR level will be increased from 180 to 225 liter per day, about 25%. The capacity of tubular reabsorption, imagine that is remained the same. So from this high volume of filtered plasma, if you subtract this level that is reabsorbed, high volume of urine will be produced by the kidneys, and this will lead to quick blood volume depletion. As we mentioned, GFR should be maintained constant by fluctuation of arterial blood pressure in a wider range. There are three key mechanisms for autoregulation of GFR and RBF: myogenic, tubulo-glomerular feedback, and glomerulo-tubular balance, known as GT balance. These mechanisms are crucial in the regulation of body fluid volume and arterial pressure. There's a point here that even with this control mechanism, change in arterial pressure will change the renal excretion of water and sodium, known as pressure diuresis and pressure natriuresis. Pressure diuresis means that by increasing blood pressure, we lose water from body, and also by increasing blood pressure, we lose sodium from body. In this figure, you see the relation between mean arterial pressure and the renal blood flow and also GFR. Through different range of mean arterial pressure, you see that within a range, the renal blood flow and GFR is maintained as it is stable and is not changing. As we mentioned, from 75 to 175, in this range, even by decreasing of blood pressure from about 95 millimeter of mercury, that is normal mean arterial pressure, if we go higher or go lower to 75, at this range, the renal blood flow and GFR is maintained. But autoregulation is for GFR and renal blood flow and not urine. You see, by increasing blood pressure, urine output is increased. For example, in 95 millimeter of mercury, the normal urine output is 1 milliliter per minute for both kidneys. By increasing blood pressure, the urine output is doubled or even tripled, and more blood volume is increased. Or with decrement of blood pressure, you see that the volume of urine is decreased, and less than 50 millimeter of mercury mean arterial pressure, the urine output reaches the zero level and not urine output will be experienced. Out of the range of autoregulatory mechanism, increasing blood pressure will increase renal blood flow and GFR, and decreasing mean arterial pressure will decrease renal blood flow and GFR. Myogenic mechanism implies that the vessels or the arterioles are resistant against stretch. For example, if due to the increased blood pressure, the walls of afferent arteriole are stretched, the permeability of the smooth muscle to calcium will be increased due to the activation of a specific type of mechanical calcium channel or mechanical receptors that are activated and lead to activation of a specific type of calcium channel that lead to entry of calcium to smooth muscle and contraction. And by contraction of smooth muscle, vasoconstriction occurs and resistance of afferent will increase. This increased resistance is important in protecting a glomerular capillary from pressure damage. In hypertension, this can lead to damage to kidneys, and especially in chronic hypertension. And this mechanism is so protecting. But as you know, by increasing the afferent arterial resistance, the hydrostatic pressure will remain normal and the GFR also will be maintained. And in this way, this mechanism can control GFR. Here you see that for a normal mean arterial pressure around 95 millimeter of mercury and a given hydrostatic pressure at the level of glomerular capillary, we have a normal GFR about 125 milliliter per minute. But for any reason that the subject experiences hypertension and mean arterial pressure is increased, sudden increment of pressure will stretch the walls of afferent arteriole and will increase hydrostatic pressure for a little period of time, and this increased hydrostatic pressure will increase GFR than normal level. But due to myogenic mechanism and contraction of the smooth muscles, and constriction of afferent arteriole, even though the pressure is high, but the hydrostatic pressure at the level of glomerular capillary will remain the same, will remain normal, and GFR will be reduced and will return to the normal level. The myogenic mechanism also can be true with the hypotension and reduced blood pressure, and by reducing the stretch over arteriolar vessel can lead to a relaxation of the vessels and increasing the blood flow to the glomerular capillary, and in this way help to maintain hydrostatic pressure at that level and maintain GFR. The most important autoregulatory mechanism to maintain GFR in its normal range is the tubuloglomerular feedback. Considering the structure of nephron and its relation with afferent arteriole, glomerular capillary, and efferent arteriole, you know that the initial portion of the distal tubule pass in a way between afferent and efferent arteriole in a close proximity with glomerular capillaries. The tubular cells in this part, known as maculodense cells, are specialized cells that are sensors of sodium chloride in this part. Next to maculodense cells in the initial portion of the distal tubule, in the afferent arteriole and efferent arteriole wall, there's specialized cells known as juxtaglomerular cells. Overall, these two structures, the maculodense cells and next to juxtaglomerular cells, together is known as juxtaglomerular complex or apparatus. This structure monitors the delivery of sodium chloride to the initial portion of distal tubule, and if it is fluctuated, if it is increased or decreased, will change the resistance of afferent and efferent arteriole and will change GFR in a desired manner to return the GFR to its normal level. At the normal GFR, the normal delivery of sodium chloride occurs at the juxtaglomerular apparatus or complex. Let's see what happens when GFR decreases or increases, and what is the response of this apparatus for this change. When GFR is increased for any reason, for example, due to increased mean arterial pressure due to hypertension, acute hypertension, from, for example, 95 millimeter of mercury to 110, the GFR will increase initially, for example, from 125 to 140. When GFR is increased, the delivery of sodium chloride to the initial portion of distal tubule will be increased. because of the increased flow rate of sodium chloride through initial part of the nephron. So what will happen? Maculodense cells will sense this increased sodium chloride and will signal to the juxtaglomerular cells and will change their resistance in this manner. The afferent arteriole should be constricted and the efferent should be dilated to reduce hydrostatic pressure in the glomerular capillary and reduce GFR. And by reducing GFR, the sodium that is delivered to the juxtaglomerular apparatus will be normal. And in this way, the GFR is regulated and returned to its normal level by changing the resistance of afferent and efferent arteriole in a desired manner to correct the GFR. And the opposite will occur when GFR is decreased. For any reason, for example, due to hypotension, that the mean arterial pressure is dropped from 95 to 80, the GFR will be decreased at first, initially, from 125 to 110, and the sodium chloride delivery to juxtaglomerular apparatus or maculodense cells will be reduced. And what is the autoregulatory response? To correct the GFR, the reduced GFR, the afferent arteriole should be dilated and efferent arteriole should be constricted to increase the hydrostatic pressure inside glomerular capillary and increase the filtration of plasma and again return the reduced GFR to its normal value 125, and the sodium chloride delivery to maculodense cell will be corrected and normalized. So the tubuloglomerular feedback links the sodium chloride concentration at the maculodense cells with the control of arteriolar resistance and ensure constant delivery of sodium chloride to the distal tubule and prevent spurious fluctuation in renal excretion of sodium chloride to this part, because if the sodium chloride that is delivered to the distal part is increased, it may increase the excretion of this substance. For the juxtaglomerular apparatus and for the tubuloglomerular feedback mechanism, the main variable to be controlled is GFR, not RBF. Sometimes at the expense of change in RBF, the apparatus try to maintain GFR in its normal level. And as we have talked about it, when sodium chloride delivery to maculodense cells is increased, the afferent arteriole should be constricted and the efferent should be dilated to reduce the increased GFR. And the opposite when sodium chloride delivery to maculodense cells is reduced. Let's consider the mechanism behind tubuloglomerular feedback. How increased delivery of sodium chloride to maculodense cell lead to constriction of afferent and dilation of efferent arteriole. By increasing GFR, by the higher level of GFR, the flow rate in the loop of Henle will be increased. So the percentage of sodium chloride that will be reabsorbed in this part in the ascending limb of the loop of Henle will decrease. So more sodium chloride will reach to the level of maculodense cells, and a higher sodium chloride at that part will consume more ATP by sodium-potassium pump at the basolateral membrane, and more adenosine molecule will be produced and will be secreted from these cells. Adenosine, that is the product of ATP consumption, is a vasoconstrictor at the level of afferent arterioles. And so higher adenosine level due to higher ATP consumption, due to higher sodium chloride delivery, will lead to constriction of afferent that will reduce GFR by decreasing hydrostatic pressure in the glomerular capillary. Another mechanism is the reduction of renin secretion from G cells of afferent and efferent arterioles. By increased blood flow to these vessels, renin secretion from them will be decreased, and by reduction of renin, the level of angiotensin II will be reduced, and reduction of angiotensin II will lead to dilation of efferent arteriole, and again reduction of hydrostatic pressure and in the glomerular capillary, and reduction of GFR. And reduction of GFR return the increased GFR to its normal level. Again, the opposite will occur when GFR is decreased. The reduced flow rate in the loop of Henle will increase the percentage of sodium chloride reabsorbed in the ascending limb of the loop of Henle, and the amount of sodium chloride that is delivered to maculodense cells will be reduced. So less sodium chloride will be reabsorbed, and less ATP will be consumed, and less adenosine will be generated, and reduction of adenosine level will lead to dilation of afferent arteriole, and dilation of afferent will increase GFR by increasing hydrostatic pressure at the level of glomerular capillary. The other mechanism is the increasing renin secretion from G cells. When blood flow to these vessels is reduced, renin secretion is increased, and by the activation of renin angiotensin aldosterone system, the level of angiotensin II will increase, and angiotensin II constrict the efferent arteriole and again increase hydrostatic pressure in the glomerular capillaries and increase GFR. This GFR increment will compensate for reduced GFR, that reduced delivery that have been reduced the sodium chloride delivery in maculodense cells, and it will be corrected in this way. In this picture you see the same mechanism we have talked about it, the adenosine generation due to ATP consumption due to sodium potassium pump potassium pump activity, and also the effects that we have talked about it. Adenosine lead to vasoconstriction, and also reduce renin secretion that finally will dilate the efferent arteriole. In this diagram you see the same mechanism that we have talked about them. Consumption of high protein foods increases GFR somehow by deceiving the juxtaglomerular apparatus. What is the mechanism behind this? How high protein consumption increase GFR, the level of glomerular capillary. It is the role of tubuloglomerular feedback. By increased amino acid levels at the plasma and increased filtration of amino acid in the proximal tubule, their reabsorption will be increased, and as you will, we will talk about it in the next sessions about the mechanism of amino acid reabsorption in proximal tubule. It is in need of sodium reabsorption for amino acid to be reabsorbed. So more sodium chloride will be reabsorbed in the proximal tubule, and less sodium chloride will reach to maculodense cells. And by reduced sodium chloride delivery, the compensating mechanism will be activated, the afferent arteriole will be dilated, and efferent arteriole will be constricted, and GFR will be increased to correct the sodium chloride delivery to maculodense cells. In this table, you see some conditions that influence renal blood flow and GFR. For example, aging, high dietary protein, hyperglycemia, obesity, high sodium intake, glucocorticoids such as cortisol, and fever or pyrogens. All these factors except aging increase renal blood flow and GFR initially, and not after damage. Initially, in the acute phase, they increase RBF and GFR, but aging mainly decreases. It can be a good assignment for you to find the reason behind how these factors, for example, hyperglycemia, obesity, high sodium chloride intake, glucocorticoids, and fever can increase RBF and GFR. What is the mechanism behind their effect? Sometimes autoregulatory mechanism cannot be effective. For example, if the reduced GFR is due to the hemorrhage, the strong activation of sympathetic nervous system will override the autoregulatory mechanism. For example, due to hemorrhage and reduction of blood pressure, the autoregulatory mechanism want to dilate the afferent arteriole to increase the hydrostatic pressure and increase GFR. But due to strong effect of sympathetic nervous system, the afferent arteriole will be constricted and the GFR will be decreased more. And it is a somehow risky state that due to severe hemorrhage and activated sympathetic nervous system, kidneys function will be failed. Different stage of chronic kidney disease is classified by calculation of GFR or determining GFR. At the normal level, or some kidney damage with a higher GFR, normally GFR is more than 90 millimeter per minute per 1.73 square meter of body surface area. When GFR falls between 60 to 90 milliliter per minute per square meter of body surface area, it is known as mild chronic kidney disease. When the GFR falls between 30 and 60, it's known as moderate, and between 15 and 20 and 30 or 29, it is known as severe chronic kidney disease. And less than 15 milliliter per minute per square meter of body surface area, it is known as complete kidney failure, and dialysis is needed. And the final clinical point for this session that is important to mention is glomerulonephritis. Glomerulonephritis is a condition that glomerular capillaries are injured, or filtration barrier is injured, and overall GFR will be decreased and protein and blood cell will appear in the urine. According to the syndrome of symptoms that is produced by this damage to glomerular capillaries or filtration barrier, we can classify two main types of syndrome: nephrotic syndrome and nephritic syndrome. Nephrotic syndrome is characterized by severe proteinuria, and due to this severe proteinuria, as you know, the main plasma protein is albumin, and by losing albumin by the urine, the subject will experience hypoalbuminemia, and due to reduced proteins and reduced oncotic pressure in the glomerular capillary level and other capillary beds throughout the body, generalized edema will be experienced, and also higher urine formation and experiencing dehydration in some way. And to compensate the reduced plasma protein levels, the lipid level in the plasma will be increased and the subject will experience hyperlipidemia. But the nephritic syndrome is characterized by hematuria, or appearance of blood cells in the urine, colorful urine sometimes due to red blood cells in the urine, hypertension due to reduced urination, oliguria or reduced urination or urine formation, and also accumulation of waste materials such as blood urea nitrogen or urea and creatinine in the plasma and extracellular fluid, known as azotemia, uremia and azotemia, that is due to reduced effectiveness of kidneys in elimination of waste material and damaged filtration barrier that cannot completely filter and eliminate waste material into the urine. Alright everyone, thank you very much for your time, for your caring about the subject, and I hope all the best for you all the time. Goodbye.